Dear friends, dear colleague, welcome back to the Mangano Digital Academy and welcome back to the Essential of Digital Dentistry. In this short lecture, we will talk about implant-supported restoration in particular about individual hybrid abutment. In my dental clinic, we have chosen this option for the implant-supported restoration in all cases, not only in the anterior cases with highly aesthetic requirement, highly aesthetic needs, but also for the posterior. So for the treatment of posterior implants, even in the single implants, in all cases we perform this kind of reconstruction or prosthetic reconstruction. So I will talk a little bit about this kind of reconstruction that is very predictable, very nice, and help us to help the dental technician to design the final restoration at best. In terms of prosthetic emergence, in terms of tissue handling, I think is the best option. Before to do it, let's go back to the digital dental world, let's go back to the digital dentistry. We have also here a scan phase for the data acquisition, in this case an intraoral scan, with and without the implant scan body. In order to transfer the position of the implant from the real world to the virtual world, we need to transfer it predictably. Then the dental technician will perform the planning in a data elaboration, data planning software, in this case a dental CAD software, a prosthetic computer-assisted design software like, for example, Exocad, the software that we are using in my clinic. And after that, after the design of the individual hybrid abutment has been performed, the design of the provisional crown, the design of the final crown, then all these pieces must be produced according to the state of the art. We produce our individual hybrid abutment in zirconia by milling, using powerful milling unit, 5-axis milling unit. The same units we use for the fabrication of the manufacture of the final crowns, usually monolithic zirconia crowns, in some case monolithic bridges, translucent in zirconia. In some cases with very high aesthetic demand, we can use instead copings in zirconia or frame in zirconia that can be veneered by the dental technician on a model. Anyway, the model must be 3D printed in the case, so we use powerful 3D printer for that. We can use 3D printer also for printing the provisional restoration, but the provisional restoration in resin or PMMA can be milled as well with the same 5-axis milled machine. So we have several options. In my dental clinic, I have all the digital tools. I have 2 3D printer, 1 SLA printer, 1 DLP printer, and also I have several milling units. So we have several options. And when we have all this set of file, we have all these pieces ready, we can go for the clinical application. So let's talk a little bit about this workflow for individual hybrid abutment. In a very simple case, I will show how to design an individual hybrid abutment. It's something that is more related to the dental technician world, but also it is something that we need to consider as dentists as an option for our treatment, even in the posterior sides, because it's more beautiful, it's also more functional, and it's absolutely feasible in all cases. How do we work in this case? There's an intraoral scan, first appointment, and then the dental technician for the prosthetic phase. The dental technician receives the scan and design the individual zirconia abutment and the temporary crown. Then the individual zirconia abutment must be, of course, fabricated, milled, and sintered, and then this individual abutment is cemented in zirconia extraorally on the selected titanium base in order to give the individual hybrid abutment. And also we need to 3D print our resin temporary crown. We can also mill it, it's not important. And there's the clinical application. So the second appointment, there's the delivery of the final individual hybrid abutment, that is the sum of upper portion in zirconia and a lower portion inside the implant in titanium, and also the delivery of the temporary crown. And then there's a 1 month, we can wait 1 month with the temporary crown, and then there's the design of the final monolithic zirconia crown. There's no need usually of a second scan. We can eventually make a second scan if the soft tissues have undergone particularly strong modification given by the temporary, but usually we don't use a second scan in our workflow. The dental technician simply modify the design of the crown and the cement gap for the final crown, because different material has different cement gap. Eventually what we can do is to make a scan of the temporary crown in position in order to give additional information to the dental technician to help him to model the final crown inside a functionalized area. Then we have the making of it, the milling and sintering of the final monolithic zirconia crown. We use translucent monolithic zirconia crown very often, particularly for the posterior area. And the 3D printing of the model is optional only in the case that we need to veneer on a model. So the dental technician needs to veneer on a model for particular aesthetic needs when we use a coping or a framework, but usually when we use a monolithic zirconia crown or monolithic bridge, there's no need of model, so we proceed model free, and that's the clinical application. So sometimes there's also a replica or try-in phase in order to check if everything worked very well. Usually we don't do it for the implants. We do it mainly the replicas for the natural teeth in order to check the marginal adaptation, interproximal contact point, and occlusal points, occlusal contacts. We don't do it for the implant because with the implants everything is faster and more predictable. There's no need for a check of the margin adaptation of the gaps because usually we have zero gap and we don't have any issues with that. So this is the intraoral scan from the very beginning of our prosthetic restoration. There's an implant in place, already also integrated. We capture our scan before we remove the hearing abutment, and we capture the scan of the mucosal collar of the master model. The master model and the antagonist, and the bite. For an hemi-arch, we can simply scan the bite of the hemi-arch a couple of times and it's more than sufficient. And then we place the scan body in position and then we scan the scan body. A very useful trick is to use individual customized healing abutment, but if you don't have it, you can use then a wider platform, an healing abutment with a wider platform in order not to have any issue when you place the implant scan body, because placement of the implant scan body must be perfect. The scan body must be screwed, or in the case of this implant system, in this particular case, must be positioned, inserted correctly in the position, because a wrong position is a wrong means that we transfer a wrong position of the implant to the virtual world, to the dental technician, so it's a disaster. So we need to check 2-3 times the position. Sometimes after screwing it's possible also to make an intraoral and oral radiograph to check it. I don't used to do it, I check it manually twice possibly, because I don't want to have any mistake. In this case we used a 3600 scanner, now we use a 3700 from Castellan Dental, but it's more or less the same, the principles are the same. So the implant scan body, and then everything is transferred to the dental technician. The dental technician, as I told you, replaced the scan body mesh with the scan body library file. The scan body library file is coupled to a library, a complete library of T-bases. We call it T-bases. These are the bases for the modeling. And then we can model, the dental technician can model on an individual abutment. The upper portion of the abutment is modeled for milling in zirconia. And it's very important to carefully model the whole individual abutment, particularly the upper and the lower portion. They have a lot of tools in this software, Exocad. They have a lot of tools in operators in order to model exactly as we want, individually, in order to fit the needs of that specific patient, in order to fit completely the needs aesthetically, functionally, and biologically of that patient. After the model of the upper portion of the abutment has been obtained, as we can see here, we can check the spaces and we can model the crown, and in this case is the temporary crown. The dental technician can model the temporary crown on. The space, the cement gap is usually around 0.1, so 100 micron in this case, because of the resin and PMMA prefer to have a wider cement gap in this case. And then there's the possibility to check and to control the modeling, the spaces, not only in a 3D, so not only 3-dimensionally, but also 2-dimensionally, using a series of tools available in the computer-assisted design software. We can see here, for example, in transparency, the individual abutment under the crown, under the temporary crown, restored so. And here the placement of the individual hybrid abutment plus the printed temporary crown before the characterization, and everything looks very well, and the fit is perfect, the interproximal contact point, the occlusal contact are perfect, everything works very well. The temporary stays in position for around 1 month. The individual hybrid abutment is the definitive one, the final one. So basically with this system that is screwless, a screwless implant abutment system, similar to the Bicon system. This system is the Leone implant system. You don't need to screw it, but you place in position. There's a percussion hammer, and it goes in position with the conventional implant system, even conical with the screw. Then you need to screw it perfectly, and it stays there. You can use Teflon to fill the gap between the little hole for screwing, and then you can temporarily cement your temporary crown with a cement, use it for the implants. And then you can eventually check everything for the final monolithic zirconium crown model if the dental technician needs a model. Technically, we prefer to work without a model-free with all the implant supported restoration if we work monolithic. So if we work monolithic with monolithic crowns or monolithic bridge, we avoid that, we skip this step of the models because it saves time, and also it saves money because you avoid to print the model. If needed, if for example we are working with copying, so we're working with framework, then we need to print all the time the model, and in this case of course we need to print it, and there's no possibility to skip this phase because the dental technician need to veneer over the copyings over the framework. Anyway, this is the rendering, the 3D rendering of the final monolithic zirconia crown. There's no need for another scan. Usually the dental technician can use the previous scan and only modify a little bit the cement gap in order to reduce it to 40-50 micron inside the software. Of course, there are a lot of tools operator in order to model, of course, the adaptation on the margin and everything, the area without cement. A lot of different parameters must be set according to the different material used, but the most important thing is that there's no need for a second scan. Eventually we can capture a second scan only of the temporary functionalized in position in order to give the limit for the dental technician, in order to give more information, even more information than those given by the capture of the bite or the 2 bite captured on the side for the occlusion, because the occlusion is always a very delicate step for the intraoral scanner, so it's much better to have more information. But after that, we can see we have all the information, the final crown that looks beautiful with the implant complex and everything, and the case is more or less finalized. We can deliver the final monolithic zirconia crown. The adaptation is perfect, and after all, after even in the short time, of course, we can control with several pictures, and the occlusion and everything looks perfect. Also after 5 years everything looks perfect. We have in this case the 5-year control. The very nice thing with zirconia particularly is that the soft tissue loves zirconia restoration, and this is why in particular I love to use individual hybrid abutment in all cases, also in the posterior. I don't like superstructure. I don't like to have a crown like a superstructure that closes exactly on the titanium base, because it is more difficult with such superstructure to work well and to design well the emergence profile. And I prefer to have zirconia below, because the soft tissues love zirconia below, particularly if the collar is thick, the tissues are thick and the implant is very deep. It's very useful to have an individual hybrid abutment, because we have zirconia below, we have zirconia on the abutment, we have zirconia on the crown, and the soft tissue really loves zirconia. And after years you can find a creeping effect with the tissues that are growing a little bit over the crown, and they close perfectly, and it's an effect that is more difficult to see with the conventional metal ceramic crown, but in all cases we have seen this beautiful effect with the monolithic zirconia crown. With the monolithic translucent zirconia crown we have also solved the problem of the quality, of the aesthetic quality, having anyway a very good mechanical reliability. So what we are doing here is absolutely very satisfactory from the aesthetic, from the functional point of view, and from the perspective of the biology, because zirconia is an incredible material also biologically, also in biological terms. So thank you very much for your kind attention, and consider also in your practice the possibility to use individual hybrid abutment instead of screw-head superstructure, because the quality of this workflow, in my opinion, is really high and need to be considered not only for the aesthetic areas but also for the posterior area. Thank you.